Welcome to the 8 Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back, and we have Lucas, Drew, and Mark. Good to be back with you guys again. Just a reminder to everybody, we'd love to have some communication on the Teams channel. Give us some feedback. Let us know some things you may want to talk about, as well as any feedback on the stuff we have been discussing. So want to make sure and give you guys some good quality content today here. So we're going to give each of these guys a chance to be able to talk over a topic this week in plantar fasciitis. So CPG was updated in 2023. What we're looking at from an exam standpoint is plantar medial heel pain. Most noticeable, first steps and worse following prolonged weight bearing, precipitated by recent increase in weight bearing activity, reproduced with palpation at proximal insertion of the plantar fascia, positive windlass, and negative tarsal tunnel. So you guys got a pretty good picture of what we're looking at here. Clinical practice guidelines put us in a lot of the conventional, which most everybody listening to this podcast is going to have some awareness around. Plantar fascia and gastroc, stretching mobility work, manual therapy going after improving dorsiflexion, hip extension. Dry needling is in there with some decent evidence. Neuro re-education, foot strengthening, orthotics is thrown in as well too. So we have those. I can also post that in our conversation here. As I said, what I want to get to is what you guys are seeing, what you guys are doing in the clinic around these. So let me get my timer going here for 8 minutes. And I'm going to send it over to Drew. Drew, kind of give me a picture of the typical patient you're seeing with this diagnosis.
Yeah, I have, in my mind, I typically see two general types of patients. Now, it can be a wide variety, but most of them fall into one of these two. Either it's the highly active, oftentimes runner, athlete type patient who has maybe changed footwear, changing their training volume. And then the other one that I have is kind of that usually it's middle-aged, often higher on the BMI scale, less healthy person. And maybe they're trying to get a little more active, or maybe they're just starting to develop the pain. But I'll start with that type of patient first. That one is sometimes the more difficult one. And I'm trying to remember where I heard it, but I've heard it said unhealthy tissues are often attached to unhealthy bodies. And in this case, that's kind of what I think. And so how do we get this person being active? And the hard part is because they're having more pain and, often they're like, I tried to start walking or I tried to start doing this and I started to have the pain. How do we continue to encourage that? So one thing I'm usually trying to encourage, either continuing in some sort of maybe non-weight bearing, maybe it's bike, maybe it's swimming, something where they can remain active. Or the other potential thing is seeing if they have orthotics or taping them, depending on how severe it is. If that's something that can keep them moving, I'm definitely going to try and do that. Then, of course, like the part of the biopsychosocial, you're going to look at anything up and down the kinetic chain, but I'm really looking at what are some of the other components to this, just health-wise? What's their diet look like? What does their sleep look like? What does recovery look like? Because, oftentimes they're really stressed at work, or maybe it's a new mom, or maybe it's someone who had a kid that they're trying to get back in shape. So how can you manage maybe that recovery, maybe the stress and the overall inflammation of them as well? So it's kind of a bigger picture scenario for those patients versus the, younger, healthier, and they have some training deficits.
Yeah, I think good stuff. I love the unhealthy tissues are attached to unhealthy bodies. That's kind of a big picture there. Plantar fasciitis, similar lateral elbow pain that we talked about last week. So much of a temptation to just go straight to the tissues and just think about that specific area, but treating the individual as a whole being a big key to that. So I appreciate that. Lucas, what do you think, especially for this acute irritability and what you're doing to get some things calmed down? What are you working with in the clinic here?
So now narrowing down to the tissue that we are actually talking about. The Drew gave the 30,000 feet view. More specifically in the tissue, usually in the tissue that will hurt your patient mostly is the plantar fascia intermedial attached to the calcaneus tuberosity. And that is a very tender spot. If you can put your finger right there, is usually where the patient is going to report most of the pain. Although this can refer on a C shape around the heel of the foot. My first strategy when I have a very acute is taping, decrease the pain, support that specific spot right at the edge where the heel ends and the plantar fascia starts, intermedial into the calcaneus soft tissue. That taping has a tendency to work really well for pain management, although it's a temporary situation, right? With that being said, that can be followed by triangulating in the same spot. I use two approaches, medially and inferiorly onto the calcaneus, which is usually also is going to hit the spot. Again, another temporary situation to manage the acute phase of the pain of the patient. These two can lead to insoles to support or the patient learning to tape themselves just to get that acute phase out of the way to then getting back to um, what the guidelines really suggest, which is strengthening. Some people use stretches, but I don't go that route.
I'm gonna jump in here too quick. It's a pretty rare occasion. I think I've seen this like maybe a handful of times in 14 years. But the history of this, especially if it's acute and it's like a quick onset, like I've had some people where they jump down or step back playing, I think it was pickleball, things like that, where you can actually get like a tear of it versus like the fasciopathy, the lack of inflammation. And those are ones that I definitely tape quite a bit, and then um, we'll we'll teach them how to do it just to really offload it for maybe a few weeks until it calms down as well. But make sure that you're looking at the mechanism as well because it could be a tear versus a fasciopathy.
It can be tricky because that person was wearing their favorite shoes for a year. The day before that shoe was supporting perfectly. The next day, it loses capacity of that support, and or the patient overdo an event or something that came up, and they standing longer than usual, and that will trigger that inflammatory process. But this is important to clarify with the patient so you don't go needling a tissue that is damaged by overdoing on an activity that they never do, like a hike that they decide to go. Oh, it's summer, it's beautiful again. Let's go for a hike, right? And so they step down from a boulder or a rock and or step on something that is bulky. Yeah.
Yeah, great points. Obviously, your subjective history needs to mix with the irritability. Where are they at? Does it make sense that we could have something that the body's got to heal versus is dry needling going to allow them to get moving quickly, and what could be the potential cost of that? So, good stuff. Mark, real quick from a chronic standpoint with this individual, what are you seeing, and how does that shift your potential treatment focus?
Yeah. I mean, a lot of it's gonna be similar to what Drew and Lucas already mentioned. But I would say even in the more active population of folks, there is often a lot of psychosocial factors that go into it. Even for the active individuals, their nutrition may not be what it needs to be. Their recovery is often not sufficient, whether that be sleep related or actual like breaks from activity. So addressing a lot of the psychosocial and socio and environmental factors that contribute to their active ongoing pain experience is going to be a huge part of it. And then often these folks have been, in my experience, just poorly medically managed. They've gone through the medical system and, they've gotten injections, so on and so forth. And if you look at the research around cortisone injections specifically to like the plantar fascia, if you get more than one of those, you're at a tremendously increased risk of actually rupturing your plantar fascia, but also in developing like stress fractures and other things in your foot. And so, um, trying to break that cycle of, I guess, again, poor medical management, and get their symptoms down using some of the techniques that they already talked about, and then going for active treatment that's going to help them long term.
Yeah, if I would add anything here on the chronic management of the chronic plantar fasciitis is the lumbo-pelvic stabilization program that once in my life made a world of change on the patient, and my mentor at the time was looking at me like I'm something, like, how come you never thought about that? I'm like, well, I never thought about that, so definitely chime in on that part, especially on the frontal plane movements, strengthening hip abduction, external rotators, lumbo-pelvic part. It can have a very positive effect on the patient, on the chronic pain patient.
Yeah, all good points there, and I appreciate the idea of really going ahead and recognizing that that chronic population is gonna have had a variety of medical treatment. And, it doesn't do any good to bash on other providers, right? What we wanna do here is, continue to address in a empathetic way, that where they're at is where they're at, and we have some ways forward, and we're not gonna spend a bunch of time on the past, but, if you wanted to get better, here's what we need to do, so.
Does anybody use isometric? That's a curiosity I have. I've tried, I played with it in the past, but does anybody use isometrics for these conditions?
I don't as much. Like I know some of the research with like the tendon stuff seems to do well. I tend to do more of the long, slow, concentric and eccentrics, like the heel raises with toes extended, like put your toes under a towel roll to start to load it. I I don't think I've ever tried too many isometrics for it because I don't see the fascia part as much as like how you can really load it with an isometric like you normally would with a muscle full tendon complex.
I'll use a great toe isometric for the analgesic effect of it, but um, I usually don't end up. It's usually something that's easy to for them to do at home, and so I don't spend a lot of time on it in the clinic. But I have found that somewhat effective at reducing some of the pain.
Like thoughts. All right, guys, we are out of time for this week. Appreciate the discussion, and look forward to seeing you guys back next week.